preemies. I'm so sorry. I really thought that they were up there. I was ahead of the game. I even posted stuff for Thursday. Oh well. Okay, so we're talking about preemies. You got you saw the video about preemies, and that kind of gets you in the a visual at least of what kinds of things we're going to be talking about. This is one of the biggest parts of the lesson. Lesson 4 is a lot longer than Lesson 5. I think we can cover Lesson 5 Thursday by itself. Okay. So, of course, when we're talking about preemies, we're talking about babies that are less than 37 weeks gestation, bless you. And naturally, the longer the baby's, the older the baby as far as gestational age, and gives the baby more time to mature all their systems, is all this is talking about. So the earlier they're born, the less mature. The major complications we're going to be talking about are, of course, respiratory distress syndrome, the RDS, and difficulty regulating their body temperature. That just makes sense, right? Because they're little. And then infection. The video really alluded to that, about comparing it to an HIV ward. And hemorrhage. They're generally discharged near their due date. I think the film mentioned that too. That's if everything goes well. But there's lots of ups and downs before then. But usually when parents want to know, when can my baby go home, give or take a few weeks, it's usually around the due date. So if they're 2 months early, it's going to be a long stay in the NICU. Any of you have NICU experience as far as your children, your babies? I was thinking there was somebody that had a preemie in here. Okay. How long was your baby in there? 5 weeks. Okay, that's a pretty long time. This is just a general idea if you have a very premature baby, because we're going to be talking about preemies as a group, and they're really hard to talk about that way because there's a big difference between a 36-week gestation and like a 24, right? Huge difference, almost like two different discussions. So a lot of what I'm going to be saying is generalizations about preemies. So of course it depends on the degree, right? But when we actually, this is the slide that Dr. Kilgore pulled up one day when we were expecting a 24-weeker, I think, or a 25-weeker to come in, and he was showing me this particular slide, so I went to this research and took a look at it, and he was looking at, what can we expect, and here we are with the death before NICU discharge percentages, and then death, this is later, this is like later on with their corrected age, means as they get older, and some of their outcomes here with either death or profound neurodevelopmental impairment. So it can be certainly all different degrees, but look at our chances here. I've taken care of a 23-weeker, a few of them actually, but I saw one that survived. But, like less than a pound, just it looks like a fetus. I mean, there's almost no skin on them. Their skin is completely transparent and gelatin-like, and eyes fused. Just really, really challenging to even touch and handle, much less start an IV, start multiple IVs, get changing IV fluids constantly, temperature regulation. All those things are just horrendous. But you can see why, because here's our survival rates right here. And it goes up dramatically at 25 weeks. That's a lot different than 95%. And most people are not going to try to save a 22-week gestation baby. And, it's real easy to judge these people as far as, why are we saving them? But as the film pointed out, if we hadn't tried to save the 1,000 gram babies, we wouldn't be talking about trying to save the 500 gram babies. And like I said, a 23-weeker was less than a pound. How many grams is a pound, y'all? 454. So 454 grams, and the one I took care of was 300 and some grams. So we're talking about a very small baby. But basically you've got to think about what the outcomes are going to be. If you're the mother of this baby, you want everything possible done for your baby. I mean, almost everybody feels that way. And I say almost because there are some people who prefer to just not put their child through all that. When somebody lays out all the facts and says, these are the chances that this is going to go well, they don't want their baby to suffer through all that. Yes?
Also, I mean,
Absolutely.
that's something that would probably.
Yeah, there's a lot of consideration for that, but not if you're the mother usually. If you're the mother or the father, you just want everything possible done for your baby. But there are usually people in healthcare that have some knowledge, or the ones that say, just keep my baby warm and give him some oxygen and let him pass. That's what we used to do on a judgment call. We don't just wrap a baby up and let them die, but you keep them warm, keep them comfortable, and there's a lot of people in healthcare that will say, I don't want to be, if I'm going to be in labor at 23 weeks, I don't want to be at NUSC or some big medical center. I want to be at some rural hospital somewhere where they're just going to let my baby be comfortable and let him pass, and instead of all of those interventions. But just because we can do things doesn't mean we always should. And if you're at a big medical center, they're going to do it. They're going to do it all, unless you make your wishes very, very well known. Yes. You can, but there's some of it is out of your hands. If the baby's born breathing with a heartbeat, then they're going to intervene. So you don't get a choice about all of it. And it's hard for most mothers to know what to ask for, so it doesn't happen very often. It's usually up to the medical team. But I've seen all different degrees of intervention depending on the philosophy of the physicians or the sign of the times. As we progress, we can do more, so they do more. But it's not always good, because look at these outcomes. I mean, even if the baby doesn't die right away, later, the outcomes are terrible. So it's a lot of suffering that this child goes through in the meantime. And certainly, as I said, we're generalizing, because we've seen lots of success stories, 23-weekers that are now very normal people who are, they're rare. Those are the ones they put in the paper. They don't put the others in the paper that are not so good. But there's certainly 23, 25-week babies that turned out fine and no developmental issues at all. They had a lot of interventions, but they ended up doing okay in the end. They're doing fine. But those are very rare stories. I think once you get past 25 weeks, then you start talking about a lot more success. Okay, and the two biggest systems we're worried about are respiratory and cardiac. And of course, because of the surfactant issue. Remember when that surfactant production began, you're going to need to know that. 28 to 32 weeks. So we're talking about at 28 weeks, they may not, it says it begins to be produced then. So might not have a lot at 28 weeks. And then it peaks at 35. So as a result of that, atelectasis, and this is the big problem, is that those capillaries out on the outside of the alveoli can't exchange the oxygen and CO2. So they can't get it going to the rest of the body. So that's the big problem, the hypoxia results. Ductus arteriosus is one of the biggest problems. And remember we talked about what's the reason that the ductus closes? What makes that one close? Oxygen. Oxygen. Also there's some other influences, but oxygen is the biggie. And if they're hypoxic, usually you'd think that would be, that all of it would kind of come together. But because they're hypoxic and they don't have good vascular control yet, those vessels don't constrict and dilate like others would. Remember there was prostaglandins that had to be on board. I don't know if you remember all that, but anyway, they have left to right shunting of the blood as a result of that ductus staying open. You now have a mixture of blood and excess volume of blood in the lungs. Does that make sense to you? If that ductus is open, there's a backflow of blood coming back through there that should have been shunting out. is now coming back to the lungs or staying in the lungs. Increased respiratory effort as a result, pulmonary congestion, and poor gas exchange. So ductus arteriosus is going to have to be treated one way or another. Indocin is one of the treatments, and it has side effects that can be bad, so they can't just keep on treating with Indocin over and over. I think they might have alluded to that in the video too, because it causes kidney problems. So anyway, that's one of the biggies that we look for. Temperature regulation is just a nightmare for these babies if they're extremely premature, because they don't have that brown fat until 26 weeks at least. And remember, that brown fat is essential. They're the ones who need it the most, and they have it the least. And then they're lacking adequate glycogen in the liver, which is part of their energy supply, which is going to keep them warm. This is a picture of a baby with an oxygen hood. He's not on the ventilator, so they don't have him covered up totally. But you see the cellophane? I don't know if you can see it from where you are, but there's like cellophane wrap across here, and that's just for moisture control and probably just protecting him from exposure, getting cold too. He shouldn't be in a warmer. He should be in an isolette. So I'm not sure why he's in a warmer, but they're trying to protect him some. If he had a ventilator, they would have him covered completely with cellophane on here, but since he's got to breathe, they can't do that. Things that affect the thermoregulation is, of course, they have a large body surface compared to their weight. They don't have much weight. Lack sub-Q fat, thin permeable skin, and that's just an understatement. Even if they're on the high end of the premature level, they are still going to have pretty thin skin. Because we said even normal-sized babies have some, right? They still have some issues with this. So preemies are going to be even more so. But we're talking about skin that's so thin that infection is just constant and a real problem for the skin. Increased insensible water loss, extended posture. Hopefully you understand that concept now, right? Extended posture is a bad thing. Blood vessels close to the skin surface and limited blood vessel vasoconstriction. So we constrict our blood vessels when we want to stay warm, and they don't have those abilities always. Okay, the GI system. You definitely need to remember this 34-week thing, because until a baby's 34 weeks, we can't feed them with a bottle. Because, bless you, because they can't gag until they're 34 weeks. So if we have a baby that's doing great and everything, we still can't feed them with a bottle until 34 weeks because they don't have a gag reflex. And it would be dangerous to feed anybody that doesn't have a gag reflex, right? Because of aspiration. They also have what we call weak suck-swallow reflexes. Sometimes we call it suck-swallow-breathe reflexes. It means they almost can't coordinate everything at one time, so they can't remember to breathe while they're sucking and swallowing. And so it's like neurologically they can't put it all together. So that's a real problem, just to kind of teach them how to coordinate everything, because they will just not breathe while they're eating, and then they'll desaturate. Weak cardiac sphincter, even more so than the full-term baby. Poor digestion, and this we're going to show you a picture of this one, but this is risk of NEC, or necrotizing enterocolitis, and that's due to hypoxia. That's what it looks like. This is what we are trying to, this is why we worry about abdominal growths and residuals on tube feedings and blood in the stool, those kinds of things. This is what we're trying to prevent, is NEC. Because basically hypoxia, have you ever, I don't know if they refer to this in adults when they talk about a hypoxic event and how one of the organs took a hit, kind of? You ever heard about, like, during hypoxic events, somebody drowning or something like that, that their liver took a hit or their kidneys took a hit or something like that? That's kind of how we refer to it. But in this case, the bowel took the hit, and the hypoxia basically necrosed part of the bowel, and it's not working. So it ends up getting infected. This is, the next slide tells you a little bit more about it. Inflammatory disease of the GI mucosa, commonly complicated by perforation. That's the big issue, what you don't want to have happen. And of course, if it does happen, we've got bacterial colonization. And the early signs, or the things we're looking for to hopefully prevent this, is increasing abdominal growth, bloody stools, and increasing residuals on the gavage feedings. So this would be the extreme limit, this baby's probably on his way to surgery or her way to surgery to get part of that bowel removed, and hopefully get a colostomy, and maybe a temporary colostomy, maybe permanent. But one of the sickest babies I took care of had this after he went home and had to come back for it because the mother wasn't aware, just wasn't able to keep up with how he wasn't digesting his food and that kind of thing. Things we would notice early, if you were taking care of him in the hospital. But he ended up surviving it. Okay, so that's the same slide. And then the treatment is just all the GI things you think of when somebody's got some kind of obstruction or anything like that. It's same things, just NPO, NG tube to low suction, IV fluids. Of course, we got to feed this baby somehow or get calories somehow. So if you can't feed, then you've got to do IV fluids or TPN, antibiotics, and surgery. Okay, the renal system, we said even with the full-term baby, they don't do real well with dehydration, right, or overload, even full-term. These babies, this is a nightmare. This is what I always tell them, I always hear the physicians say, even with babies that we take care of now, is that just keeping their potassium and their sodium and all that in balance is difficult because every baby's kidneys are a little bit different. But preemies, it's just, that seems like when you're taking care of a really small baby, all you do is change IV fluids because there's every couple of hours you're drawing blood from the umbilical catheter, getting results that make them want to change out all the IV fluids. So you're constantly doing that because their renal balance is very, very difficult to establish. And it's so critical to their survival as well. So, and that drug excretion time issue is compounded for them. Right, the immune system, of course, sets them up for infection. They don't get the benefit of IgG because it comes in the third trimester. And IgA in the breast milk is extremely necessary, so much so that if there's really small babies, most NICUs are using breast milk banks. If the mother can't provide the breast milk, they'll get it from a breast milk bank if the parents will consent to that, and be able to have that sent in for these preemies because it's that important that they get this kind of food. They usually have to do a fortifier with it to give them more calories and vitamins and all that, but that's much better for them if they're able to eat. That permeable skin, making them susceptible to infection. I've got a picture on the next page, I think, of a little boy I took care of. I'll come back to that one. High risk for nosocomial infections, and of course these are all the things that we do to try to prevent infection on babies. It's basically the same things we do for the full term, only even more important. This is a little guy I took care of at NUSC, and I still have his picture. I really wonder what he looks like now and what he did. But he was the cutest little thing. He had these really, really fat cheeks. When he would smile, those cheeks would just plump up. But he got an infection in his cheek. You see the surgery they had to do right here? And it's pulled his eye down. And it was from the tape for his ventilator. It took a long time to figure out what it was. But once they figured it out, it was a fungal infection that had started under his tape. And, it's just a real challenge to get anything to stick to these babies' skin. He was very premature. And this was like when he came back to visit after he'd been discharged and gone home and came back. And his mother gave me permission to take that picture of him. But it's just almost impossible to get anything to attach to their face to keep it on because it just, you don't have a good way to do that. Usually we try not to put tape on them. But his started there, and he ended up with such a bad infection, and they couldn't identify it at first. And he had to have that whole piece of skin. All his cheek muscle was where it was. So they had to take the cheek muscle out. So now when he was smiling, I wish I had a picture of him smiling. Just one side of his face just lights up, and then the other side drug down. The eye would drug down and everything. But they saved his life by doing that surgery. But I think it's a reminder of how fragile their skin is, and even that, you don't even have to have a cut or anything. It's just the infection can just get through the skin. Neurologically, this is one of our biggest worries for them because not only are they not developed, they're also very fragile neurologically, and we can still damage them by the way we handle them and everything. Most rapid brain growth occurs during the third trimester, right when when we don't have the mother to help us with that. So we still going to have brain growth and all, but you've got to really care for them carefully, or you could impede that. And this is one of the biggest reasons: intraventricular hemorrhage, rupture of the thin, fragile capillaries within the ventricles of the brain, leading to increased intracranial pressure. They have very fragile blood vessels that rupture really easily. So like a big spike in their blood pressure or change in their positioning, like where you put their body higher than their head and just have a rush of blood to their head is enough to make those blood vessels rupture. So when we change diapers on extremely preemie babies, we don't lift their bottom any higher than their head because you don't want a rush of blood to go up. So and once it happens, it's not fixable. They can put a vent in there, but it's not going to be the same once there's damage. So intraventricular hemorrhage is a huge risk for them, and this is what's going to cause, the mental restrictions and the blindness, deafness, lots of things, anything to do with the brain. It's like a lot of strokes, basically, for the baby. And hydrocephalus is the result of that. This is actually an autopsy picture of one of those, where this bleeding was into that whole ventricle there. Okay, that's depressing, isn't it? But it is very sad because it's something you don't know is happening. You don't see it happening until they do scans of the head, and you see the result of that. Okay, nutritionally, we said at least 130, didn't we, calories per kg per day, I think, on that other lesson that we were doing. But mainly just know that even though this is a smaller baby, he needs more calories per kg than does the full-term baby. So we've got to pack a lot into this small little baby. And he can lose up to 15% of his weight, so you can imagine that's a lot when you weigh a tiny bit to begin with. Usually they're going to be started on some kind of IV nutrition, and then eventually once they get well enough, they can, you just can't leave somebody on IV fluids only for nutrition for long, even TPN. So eventually you're going to have to start some tube feedings. Usually we start continuous feedings, and I'm talking about really tiny drops for a while, and then increase it very, very slowly to see if the GI system is going to accept it. And then if they do well with that, then you get higher amounts, and then you go to bolus feedings. And the bolus feedings would be, like at least every 3 hours, and then move on to later start like 1 bottle a day, and then maybe end up with every other feeding because they tire. They get so tired while they're feeding that's a real gradual process of getting them to eat. And then eventually you might get to where you're feeding them just 1 bolus feeding, tube feeding a day, and then, eventually move on to the full bottle feeding. So how old do they have to be at least before they bottle feed? 34 weeks. So that's because of the gag, suck, swallow reflexes. What's non-nutritive sucking? Pacifier, yeah, it's a pacifier. Pacifiers are well documented as very, very important to preemies. When I got my master's, we have to do research, so I didn't have to come up with my own research, but I could replicate a study. So I was crazy and didn't know what I was doing. So I chose one of the hardest things I could have done, but I chose to study this because I was fascinated that they had proven already that when you give a pacifier to a baby who's getting a tube feeding, that they gain weight faster. And they go home sooner, they bottle feed sooner, they do everything better. So I just had to replicate it, so I thought I was so smart doing that, but didn't think about the fact that once they start bottle feeding, they go back to their hospital, wherever they live. So then I had to start following babies to wherever they lived, which was a nightmare. Because they might go back to Walterboro, they might go to Myrtle Beach, they might go to Georgetown, wherever they were from, they go back there to be closer to their mom. So about the time I needed to start studying them is when I had to start traveling. So I ended up having to do my control group. Now y'all understand this control stuff, right? All this research stuff. Not you might have already. But anyway, my control group, they finally agreed to let me use discharged patients as my control group. So I had to go to medical records and go through hundreds of charts to find, how much babies weighed every single day to see what happened. So what I did is I studied babies that got a pacifier every single time you gave a bolus feeding. You tube fed them. And you had to purposely start it. You started the pacifier 5 minutes before the feeding, and then you kept it going 5 minutes after. And then I compared that to the group that may or may not have gotten a pacifier. There was no rhythm to it. They just, if they were fussy, they got one. If they didn't, it didn't matter. And so that meant I had to go give a lot of donuts to a lot of nurses to help me figure out, to do this timer. We had an egg timer. They had to time it and had to document everything as a research study. So, but anyway, what's so cool about it in the end, after all of that, is that I was able to show it really did work. I can still remember the numbers because it was like 21 grams a day that babies grew if they didn't get any rhythm at all, and 25 grams a day with the pacifier. And that's been replicated over and over, so it's very proven. It has something to do with the act of sucking releases the saliva and the digestive enzymes and all that. So in other words, if you just walk up to a baby that's sleeping and just keep on and just give him this bolus feeding, and then 3 hours later you give him the bolus feeding, he's still sleeping. You haven't woken him up. He doesn't associate eating with getting full. So he just gets full every 3 hours, but he didn't suck or he didn't have to work for it or anything. That's not the same, and it's not the way we're supposed to work. So anyway, so it's very well documented. That's why I get a little upset about some of the pacifier issues. Yes, I know that we don't want our 3-year-olds with a pacifier, but when they're babies, they want to suck, and they aren't always hungry. They just need to suck, and they're fussy, and some babies aren't fussy. They're fine without it. But the ones who are, I just don't think I personally, with my experience in it, a lot of people would argue, okay, so I'm not saying this is scientific. I'm just saying my opinion is they need their pacifiers. When they're fussy and they're unhappy and they're discontent or they're in pain or they're having a bad day, they need something to suck on. They can't suck on mama or a bottle all day long. So I think it's just one of the nice ways that we can comfort these babies, and not only, it's, what's that?
Because I know my daughter.
You might see what in some of the pictures that like you're talking about. Oh, he got septic. Yeah. Wow. Yeah, it's really, really important for them for sure. And I think it's important for all babies, but I know there's a lot of babies that are fine without it as well. So there's research both ways on full-term babies, but preemies, it's well documented. Okay, so sorry, I didn't mean to get off on that too much, but just so my study was non-nutritive suck, the benefits of non-nutritive suck, because if they gain more weight, that means they mature quicker. Not only do they come out of their isolettes quicker because they're warmer, and they start eating they can do bottle feeding quicker, and they go home quicker. It's all documented. How the discharge time is completely different. It's very, very important. So gradual introduction to nipple feeding, and of course they use a more concentrated formula for preemies because you want more bang for your bucks, right? You want more calories in a smaller amount of fluid. And then if you do breast milk, you usually have to put milk fortifiers in it, just a powder that you add to it that adds the vitamins and some of the calories actually, and multivitamins. Okay, methods of feeding. Let's see, how much of this have we not talked about? We already know about the respiratory rate issue, right? Never feed them before they're, if they're breathing faster than 60. Progress gradually. And this is important, should only require 15 to 20 minutes to preserve energy. So I don't think we've had very many preemies this year to actually feed that we could actually do this on. But sometimes when students are feeding babies, I'll say, well, we'll give it a try, but if they're slow, we have to give the baby to the staff, or I have to feed the baby. Because if we take him so long to feed the baby that he's using up more calories than he's taking in, then we kind of defeat our purpose. And that's what it means. It should only take 15 to 20 minutes to feed him. And so if it's taking longer than that, probably he needs to back up and go back to tube feeding some. Because if it's taking that much energy to feed, you're not getting the benefit of the milk. So that's what that means. And there's lots of ways we can tire them out besides just holding them and feeding them incorrectly. You can't rock them at the same time. They neurologically can't handle the moving. You know, we want to rock when we're feeding a baby. We just love to rock and feed a baby, but that's just too much room movement, too much stimuli for them. So you have to keep everything quiet and still and controlled for them to be able to process everything. And then breastfeeding, usually we really, really encourage it, and they usually can go to breastfeeding quicker than they could have gone to bottle feeding. So even when they get to the 34 weeks. Okay. And this is just all the tube feedings, continuous or bolus. Used when they're on the ventilator, even when they're on the ventilator, if they're old enough and they're able to, or they're strong enough, then we can bolus feed while they're on the ventilator. Usually they're too sick to get feedings at that point, but sometimes they're on the ventilator for a really long time. Okay, I think I covered all that. All right, these are some of the complications of prematurity. Apnea is huge. Because remember I told you they just forget to breathe kind of. I mean, I say forget, but it's neurologically they aren't, they're just not clicking, and they don't get the stimulus to breathe. So remember, greater than 20 seconds is the only time we're going to call it apnea for any baby, full term or preemie. But these babies have it a lot, and they'll always have a cardiac apnea monitor, even at home probably. Shaquana, how many weeks was your baby? 30. Oh, that's pretty young. Yeah, 30. That's very early. So you probably went home with a cardiac apnea monitor, or he was stable. That's really good. On oxygen. Yeah. I bet.
They said because the more time you really had it.
Wow. Yeah. Yeah, you go from NICU where everybody's watching him to go home, and then going home is scary. Because then you don't have that monitor that's going to go off. That would be really scary. I definitely want me a monitor. but he didn't need it. Thankfully, he was that strong, so that's good. So the apnea is huge. Remember, if you stop breathing, what's going to go down next? O2 sat, and then what? Heart rate. So then so we call it apnea and bradycardia, because by the time the heart rate's affected, they've been without oxygen a little bit for that to happen. So we call it A's and B's, or apneas and bradycardias. PDA we discussed, respiratory distress syndrome. We're going to talk about in more detail. IVH I mentioned for the brain, right? Neck, jaundice. Huge problem, because their liver is even more immature, and they have even more red blood cells than the term baby. So poor things, they can't win. Everything is stacked against them, isn't it? And hypoxia causes what? Production of more red blood cells. So they have even more if they have any hypoxia, which most preemies have at least some hypoxia before they get treatment. And then sepsis or hypoglycemia, really big issue too, and then sepsis. So those are our complications. More, I don't know why I have some of them on here twice though. Anemia, electrolyte imbalance, and the sepsis, of course, was from any source. I talked about the skin, but it also can be from any other source too. And just like the PICC line was the source for Shaquana's baby. So you can imagine that's a real big problem. Okay, long-term problems. This is one of the things, like like we were saying, that sometimes you can get through the initial part and survive all that, and then long-term we've got learning disabilities and hearing problems and all kinds of things. But these are some of the big ones. The retinopathy of prematurity. We used to think that a little bit of oxygen's good, so a lot of oxygen must be better. So we used to give way too much oxygen to premature babies. And that's what happened to Stevie Wonder. That's why he's blind. He was a preemie, and he was given too much oxygen. He was born like in 1950. So he, when you give too much oxygen, they showed it in the video, if you remember, how the blood vessels detach from the back. So the oxygen has an effect on that, and a negative effect. So our goal is always to give only the amount of oxygen a baby needs to get a good saturation, not more than he needs. And we're always trying to wean it off. We're always trying to wean, because the other thing is they get sort of addicted to the alveolar pressure, which I think is, well, here it is under bronchopulmonary dysplasia. Damage to the alveoli caused by positive pressure ventilation and high O2 concentrations. This is the reason a lot of babies don't get to go home, is BPD. It just means that their alveoli somehow get sort of damaged by the fact that they've had that pressure of the ventilator. And even when they go to CPAP, they just get, the alveoli don't work correctly. The CO2 and the O2 don't exchange properly. So they are sort of like, you can get them down to like 23% oxygen, just oxygen, and they're doing great. You take them down to 21 at room air, and they're going to have apnea and bradycardia. And they can be in the hospital for months just because of that. So these are the kids you're going to see in the mall who are in their stroller, and they have an oxygen tank. They look like a preemie and, maybe a toddler even. They get to be older, and they still have to have their oxygen, and that's the only main thing they had left, that they cannot manage without that tiny little bit of oxygen. So that's BPD, really important issue for them. And also, they have to take a lot of drugs for this, the cortisone, so they end up having all those side effects. So these top two are very, very common. And then speech defects, neurological deficits, anywhere from cerebral palsy to just mild learning disabilities. It could be any level of neurological defect. Auditory is not just because they're premature, but because a lot of the drugs that they give them have that side effect of damaging the ears. And what's the one, gentamicin, isn't it, that is known for that? And one of the main ones we give them. So hearing damage, but you're trying to save their life, so you kind of got to give up that risk sometimes, and they end up having hearing deficits. 5 times greater risk for SIDS for a preemie. Respiratory infections, like a chronic problem, we're talking about long-term stuff, so they're going to be more likely to get colds easier, to have all of those bronchitis issues and all that, and then of course an increased mortality rate. And as I said, we're generalizing, so we're talking about very premature babies. Okay, this is a concept that you need to understand, chronological age versus corrected age. You might have learned this in peds, but chronological age means whenever your baby was born. So let's say our baby was born 2 months early, and he's 6 months old today. So his chronological age is 6 months. Okay, he was born 6 months ago. But his corrected age, you're going to subtract that 2 months that he was early. So he's really what? 4 months. So you're going to his corrected age would be 4 months because he was born 2 months early. The reason that's important is developmentally we only expect him to behave as his corrected age. So when you're doing the Denver developmental on him, you don't expect him to be his chronological, only his corrected age. But that's only true up to age 2. At age 2, they're supposed to have caught up, and you no longer correct for their prematurity. So that's when there are true developmental delays. So you've got a 1-year-old that's acting like a 10-month-old, you're not worried. You're not thinking that's a developmental delay. That's just a result of prematurity. But when he's 2 and he's acting 2 months earlier, then that's a problem. All right, so you probably have a test question on the chronological versus corrected age. You'll have to know how to calculate that. Anybody not get that? However much they were early, you just subtract that. And it's usually done in months, not weeks. So if it was baby was a month old, then you subtract a month from however old he is now. And you'd say the 6-month-old, you would treat him as 5 months old. Really important when you're doing Denver developmentals and things like that. And you're really tracking these babies constantly to see if they have any issues that need to be addressed. So that's why it's so important. Remember we're talking about how you need to be able to picture every one of these babies that we've discussed and what does this baby look like. And this is how this baby looks. Pink or ruddy, transparent skin with visible blood vessels, and again we're generalizing. Decreased subcutaneous fat, abundant vernix and lanugo depending on what part of the part of the gestation they were born, but often with abundant vernix and lanugo. Head appears large. Skull bones are soft and pliable, and their skull bones have not met yet, so sometimes they have a fontanelle that meets the other fontanelle, goes all the way back, never is wide all the way back to the back. So the bone growth hasn't occurred. Fontanelles are still going to be soft and flat, and the ears are just really soft and pliable, so that you can fold them and they stay folded. If they're real preemies, they just, wherever you put them, they stay. Those ears don't have any spring back to them because they haven't formed the cartilage. Nails soft and short, female prominent clitoris and labia minora, and the male undescended testes, and sometimes scrotum is very hard to even identify. And if they're really born at a very young age, you almost can't tell which sex you have. Posture is flaccid and frog-like. Remember, no tone. Cry is weak. Poor reflexes, especially their suck and swallow and gag. And uncoordinated jerky movements. Okay, look on page 592 with me. Some of this I just didn't repeat in a slide because it's really good in the book. But on 592, under respiratory function, these are some of the reasons. The same things we sort of talked about with full-term babies, but even more so with these babies, is the bronchi and trachea are so narrow that mucus can obstruct the airway. So it's almost too small to even suction out, either because you'd have to have such a small catheter that mucus would plug up the catheter. So we run into all those issues with respiratory for very premature babies. Positioning is helpful for the lungs. So preemies are the exception to the supine position because they're usually on a ventilator anyway. So putting them on their abdomen is better for their ventilation, because it kind of opens the lungs up. Because when they're on their back, their muscles in their chest are so weak that they sort of cave in. They don't have the musculature to open up their lungs. So if they're on their abdomen, they do better. So if they're on a ventilator anyway, then we spend at least part of their time on their abdomen. Let's see. And we're trying to avoid bending their trachea. It says there that it will collapse. Remember, we do the car seat test in the nursery here? Any of you got to see that? A couple of you did. If the baby's less than like 5 pounds, we do a car seat test where the parents have to bring in their car seat to the nursery, and then we put them on the cardiac apnea monitor and make sure that in that car seat their trachea doesn't collapse. So basically they don't bend their head and end up apneic because of their trachea. So that's any small baby. It doesn't have to be a preemie. And then at the bottom of that first column it says weak or absent cough or gag reflex. So therefore we got more issues with mucus and respiratory danger there that we have to watch out for. And then there's a little section that says signs of respiratory distress. They're really the same signs that we learned for the full-term baby. You're just more likely to have them. Tachypnea for sure, and so it's a diminished air entry, so that's because of that small trachea. And look on page 592 for the neutral thermal environment information, same page. Some of the things that we're doing are basically the same except for number 2 under there says warm and humidify oxygen, because we do that for all babies, but these are especially important that we don't let this baby get chilled because we're giving them cold oxygen. So it's really important. And then the double-walled isolate, and then it talks about the plastic wrap on number 3 in the middle of that paragraph, plastic wrap over the baby and pipe in humidity. They call that swamping. That's what I was saying, that if they're on the ventilator anyway and you're and they're in a warmer, then they're going to wrap the whole warmer with saran wrap basically, and then we're going to pipe in humidity. So that it's like drippy in there. It's like a rainforest in there because it's really moist, because we want them to have a super moist environment, because think about what they came from, what they should be in utero in a very moist environment, right? So we try to replicate that the best we can. I think the rest of these are probably the same. Opening the portholes, number 8. Just we're very careful about how we open the portholes on the isolate and how we close them, because we don't want any loud noises and drafts, so we're careful about protecting their little environment. That isolate is basically their womb, their uterus, right? We're kind of replicating mama as best we can. Okay, the rest of that's pretty similar to what we already learned about full-term babies. Prevention of fatigue during feedings, page 594. I probably covered some of this when I got ahead of myself. But on the bottom of the first column on 594, the second paragraph talks about measuring abdominal growth, auscultating the abdomen, make sure their bowel sounds. It talks about NEC some, residual feedings, all indications of intolerance. So however you were feeding the baby when that started happening, you back up. You know, if you'd gotten to where you were feeding them once a day with a bottle, you're probably going to stop doing that and back up to going back to all tube feedings. If you were starting to do bolus feedings and this happened, you probably go back to continuous drip feeding. So you go backwards, you probably progress too fast or something. So I think we talked about all those different signs. You need to know all those. Just the signs that I gave you earlier of how do you know a baby's not tolerating their medication, their feedings. Okay, on the second column, I think the only part of this I didn't probably cover is putting them on their right side. So either the right side or on their abdomen, just to facilitate the stomach emptying. And they don't have as much risk of aspiration as they would when they're on their back. So like I said, preemies are an exception to that rule, and that's because they're on a monitor. You know, they're usually on a monitor. So why do we do supine on term babies? To prevent what? SIDS. So if you have a baby on a ventilator and on a monitor, then you don't have to worry about SIDS, do you? Because you're going to know if this baby stops breathing or has any issues like that. It mentions occupational therapy in that same paragraph. I always say that if I had known what an occupational therapy did in a NICU, I probably would have been an occupational therapist, because I never even had any clue what they did. But they do amazing things in the NICU and with babies, I guess with peds too, but they know every muscle in the face and in the jaw and in the tongue, and everything that this baby could be doing wrong as far as feeding, they can identify it and fix it. It's amazing. I learned a lot about feeding babies from occupational therapists, and they're not only that, but they work on the speech parts of the face and the mouth and all those things that preemies are going to have problems with, but they can really help with feedings. Prevention of infection is the next section. That's probably the next slide. Yep. So that prevention of infection part, let's see if I covered everything. Oh, fingernails. Talks about fingernails on here. You know, there's some documented cases, one with a couple of deaths in a NICU that were linked back to one specific nurse's fingernails because she had artificial nails. And it was one of those classic cases that ended up changing policy and everything. But can you imagine how that nurse felt to know that her fingernails were what resulted in 2 deaths in her NICU? Because there's no way to clean under artificial nails the same way. So that's how the first time they figured all that out. Even though she was cleaning her hands, it just wasn't effective. So you can imagine how much more important it is in preemies because their skin's so fragile. We could just scratch them, and just handling them, we could really cause a major infection. It gives you more information here, but I'm going to stop there because we got a whole section on sepsis that we're going to be talking about and some of the clinical signs in the next chapter. So sepsis is definitely an issue, but the signs and symptoms are going to be covered real well in the next chapter. Skin to skin and kangaroo cares on 595, even more important in these babies, soon as they're stable enough, and even with the ventilator. In the video we saw that the child still was on the ventilator and the parents got to hold him finally. What was his name? Aiden, or what was that the little boy's name? No, Jaden was the girl, wasn't it? What was the little boy's name? Neil. That was it. What is that? Neil, yeah. Okay, individualized developmental care. This isn't in the book so much. It is, but in a different form. But this just means what we're talking about is basically on 596 is some of it. But what we're talking about is how do we support these babies developmentally, considering the fact that they're not inside of mama. Let's come back and start there. Let's take a break for 10 minutes and we'll start with this part. I need to go get the basket of candy for everybody. Okay. I guess I ought to know this stuff by now. All right. So developmentally, there are lots of things that we do in the NICU for these babies. We've got to, we got to create an environment that's good for them. And so we're trying to support them in lots of different ways. This baby has what we call nesting, when you put the blanket around like this, because remember, they can't flex their muscles. They're extended too much. So everything we do should be encouraging flexion. So like we call it the W position. When preemies are born, they're like flat up against the mattress like this in the W position. Like their shoulders are back, their elbows, every part of them touches the mattress. Same with their legs, the frog-like position. So we want to pull all of that in so that we encourage hand-to-mouth behaviors, so that, before we first started saving babies so young, they would get old enough that they couldn't actually put things in their own mouth because we just didn't know how to prevent those problems back then. But so we want to roll their shoulders forward, keep their knees bent in and their thighs bent, hips rolled in. Everything is flexed as much as we can make it. So that's what they've done here. They have a way too big diaper on this baby, but because we don't want big diapers encourage the legs to be spread apart, and we want the legs to be together. So we actually did homemade diapers usually if we had really preemie babies and they didn't have diapers that small sometimes, then we would just use gauze or something like that to try to catch as much as you could, but never push their legs apart like this. He's smiling, I think. This is just a quote about some of the things that we do to babies, and it kind of covers a lot of things. We thrust them into an environment with constant bright lights, sudden loud noises, temperature changes, and cold hands, subjected to an environment without the containment and movement of the uterus, one in which people poke, prod, and stick things into him in a variable and unpredictable manner. The infant must constantly adapt to new faces, shapes, odors, touches, and voices. And this is Susan Blackburn's done huge amount of, a nurse who's done huge amount of research on developmental care in preemies. He may be able to feel, hear, and sense his world, but he is unable to control it or even to withdraw from it. So it's something to think about, that even, they don't have when they're very young preemies, they don't even have the ability to withdraw from pain, like to jerk their arm away or to even move their head away, to let you know that they're in pain. So we've got to be constantly anticipating those kinds of things that they can't do for themselves. So it's really sad when you think about what kind of environment they're born into, this craziness of loud noises and bright lights and all of that. We're so much better in NICUs now at designing places that are more adept at helping with that, but still there's just no way to totally replicate the mother. Bright lights, and not just that they're bright, but that they're not cycled, so they don't have day-night. So now the NICUs are designed in such a way that you're able to work on one baby without waking a whole bunch of other babies up to turn on all the lights. They try to make things much more friendly for the babies. Excessive and unpredictable handling. So this is when we talk about clustered care and how we don't startle babies and just enter into their world and bother them, but we need to have some sort of predictability about it. Noise levels, a major issue. We're going to cover a different slide on that one, and then temperature changes. So this is just some examples of some sound levels in an intensive care unit. And if you think about that, about 50 is like a traffic noise, the equivalent of the decibels of traffic noise and noises that are sort of obnoxious to us, but can be damaging to newborns or premature newborns. Then these are some of the, this is what quiet is considered in the NICU. Talking, we tend to talk over the baby while we're doing things. Some of the really, really harmful ones are the IV pump, and using the top of the baby's isolette as a surface, like just setting a formula bottle down is really loud, so that's a big no-no. You keep a quilt on top of that. Usually we ask the parents to bring in a quilt that they want, that they like, and put over the top, but then there's usually a shelf mounted above that so that we end up putting things on that. That's bad. That's loud enough even up there, but at least you're not slamming it on the baby's. That's his room, his home, and all of that noise. One of the biggies that was that we try to prevent, that this has really became an issue that somebody studied, is that bubbling in the ventilation tubing. I don't know how much ventilator care y'all have done, but it gets full of water, at some point, and you got to pick it up and kind of drain it. And if you don't do that, it just bubbles, which is not such a big problem, except for if you're a preemie and it's echoing into that isolette. And somebody measured that and did some research on it and showed that it was very damaging to babies' ears, that sound of the bubbling. Anyway, just some of these examples here, slamming that porthole. So some things that we could control, so we need to be very aware of. Clinicians should be encouraged to pay more attention to an important source of noise pollution, which is us. We're usually the reason that the baby's having all these issues, because of us talking too much over the baby. Having traffic areas near very fragile babies, a bad idea. And so we do something called minimal stimulation. Every unit might call it something different, but they basically are trying to, it's kind of a law in the NICU, you're not optional, that you do certain things for the babies, such as the clustering of care. Every 2 hours we would get the vital signs off of the monitor and not disturb the baby. Y'all probably do that with adults as well sometimes. It's sometimes acceptable if it's in policy that you do it that way. Covering the eyes and ears, no loud music or voices. Place the infant on the bed scales and water bed. In other words, a bed scale that stays on all the time, so they don't have to be moved off of the bed to be weighed. And their weight is so important that they have to be weighed every day. Sometimes a long time before they get their first bath sometimes, because it's just not important compared to all the other things they're dealing with. And then I mentioned that when you're changing the diapers, never lift the legs higher than the baby's head. These are just some of the little signs that you see on babies' beds that tell people what this individual baby needs and likes and responds to or doesn't like. So some of the celebrations that you have for milestones. And then this is not just true of preemies, but it's even more important in preemies, but infant engagement cues means the things that show us that whatever we're doing is working and that this baby is engaging and learning and kind of connecting with us. So these are all those positive things that we look for. So, you know, some of them are kind of obvious, like the looking at caregiver's face. You can just tell when a baby's kind of focused on somebody while they're, you know, in that quiet alert state, right? So those are all the good things. And then these are the bad ones. These are the ones that are telling us that we're not doing something right, or that the baby is overwhelmed. Not always that we're not doing it right, it's just too much. The baby can't handle it. So these are kind of hard to pick up on some of them, but some of them are pretty obvious as well. Back arching is very well documented, or we all know how to prevent it in preemies. And remember we talked about the tiptoes, not letting them be on their tiptoes if they were in preemies. Wasn't that you, Patrice? Was that you telling me about a baby that you knew? Trying to use the shoes to keep them from. So that's one of the things. The back arching is part of that. Like if you put a baby in a walker and they do the tiptoes, they also arch their back like this, and that's what we're not encouraging. We want flexion, not extension. So we want them to curl forward, not backwards. So that's a really bad habit for them. So we do things to keep them from back arching. But they do that when they get mad. They just start the arching thing. They put their head back. Hyperextensions. Let's see, which one is the real... The finger splaying is one of the most classic ones. I put it over here to tell us that. It's called the halt hand, and it's just, if you will watch babies now that you know this, even full-term babies, they will do this all the time. And the people say babies don't talk, but they talk to you if you just know how to read their signals. But they do this. They will put their hand in front of their face, like, how clear is that? If we can't read that, get away, stop, leave me alone. And it really does mean they're fatigued, or they're overwhelmed, or they're just aggravated, whatever. So you have to learn to read their signals. So that one's a big one. Sometimes it's even things like this, like the hiccuping and yawning. So color changes. So these are the things we've got to learn to read on the baby. So these are disengagement cues, timeout cues, things like that, infant disengagement cues. This is about looking for big red flags with parents, because think about it. If you've got a preemie that's very fragile, it's so long before the mother gets to take care of her baby, and the dad too. You can see. Remember they talked about the helplessness that they felt about taking care of that little boy, that they couldn't hold him and know how to help him. But if every time they come in, the baby's alarms are going off and they're scared by all that's going on, they don't learn how to engage with their baby. And instead, it's almost like the nurse is taking care of all the needs of this baby, and mom and dad just feel helpless. So therefore, sometimes bonding does not occur. And sometimes it's on purpose. They're like expecting this baby not to live, maybe, so they're almost protecting themselves and don't get too attached. So you can see some of that sometimes when you take care of them as well. But if they talk negatively about the baby, failing to give the baby a name, they just won't name him because they're sort of just not going to get that attached to him. Visiting or calling in frequently or not at all, refusing offers to hold and learn to care for the infant. These are all big red flags. Showing a decrease in or lack of eye contact, discussing infant in impersonal or technical terms, and not talking to or smiling at their infant. We see all different levels of that. Other things that we need to do for these babies is to, I showed you the positioning would be that kind of nesting kind of positioning. All different ways that you can do that on their side, on their abdomen. There's special ways that you learn how to do that. Skin care is a big issue. They do sheepskin mattresses usually, or different companies come out with different materials that they will promote for the skin care. Prevention of infection. Parent-infant attachment, and then preparation for discharge. For the discharge thing, it's a lot of stuff. It's going to be mom and dad are going to have to learn CPR, cardiac apnea monitors. They're going to have follow-up with pediatricians, probably a cardiologist if they're PDA, neurologists, audiologists, speech therapists, occupational therapists, physical therapists. That's how many people this person needs to sustain life. Shaquana, did you have to do some of that? Oh. Yeah. I imagine if he really had a lot of problems, the respiratory issues and all that too. So discharge is a really big deal, and it takes a good while to coordinate it. There's usually a caseworker that is just assigned just to some of the babies. They can't even take care of all the babies. Okay. So obviously y'all going to be asked a lot about preemies on your test, because that's a big part of our focus. And preemies are kind of they're little babies, so they have a lot of the same problems that we talked about with full term, but certainly some very unique needs as well. Let's think back. Make sure I don't have any notes in here I need to share. Hang on. Just make sure I didn't miss anything looking through my book here. Here it is. Before I move on. Sometimes I talk right off the top of my head, and I'm afraid I'm going to leave off something important. Yeah, we're good. Okay, any questions at all about preemies? You know more than you ever wanted to know, and then some, right? So let me close this one off.